All right. Good morning, everybody. Thank you for joining us for Astarte Medical's webinar hosted by Dr. Katherine Gregory, Building a Better Baby Biome, Caring for our Babies and Their Bugs. I'm Tammy Jansen, co-founder and CFO of Astarte Medical. For those of you who don't know us, Astarte Medical is a precision nutrition company providing digital solutions to support nutrition and feeding practices for preterm infants in the NICU. We're hosting a series of educational webinars this year, all focused on the growth and development of preterm infants and the importance of feeding, nutrition, and gut health. I'm thrilled to share our incredible lineup of upcoming speakers with you. You can find the details for all of our webinars, both past and future, on our website, so please check it out. Please also mark your calendars and join us for our next webinar on October 6th for a presentation by Dr. Gotham on achieving nutritional excellence, improving the quality, safety, and value of NICU nutrition. So let's get started. We'll have plenty of time for questions at the end. Please feel free to post your questions throughout the presentation in the question box. Just scroll down and you'll find it at the bottom of your screen. We'll compile the questions and get to as many as we can at the end. I'm pleased to introduce our esteemed presenter and expert in the field of neonatal nutrition and gut health, Dr. Kate Gregory. Dr. Gregory has dedicated her research and clinical career to improving health outcomes for preterm infants and their families, focusing primarily on GI diseases, nutrition, the microbiome, and its role in gut health for these fragile patients. I'll now turn it over to Dr. Gregory.
Great. Good morning. Oops. Okay. Good morning, and thank you, Tammy, for the kind introduction and to talk with all of you this morning about one of my favorite topics, the infant intestinal microbiome. So I'm sure that everyone listening this morning is fascinated by the microbiome and the impact that it may have on human health. And while this has captured the attention of many of us in the scientific community, it's also captured the attention of the public, as we see many articles featured in publications like the New York Times and others. And yesterday, I just took a minute to see where we were with publication on the microbiome. And as you can see, it has increased exponentially almost 170 times in the last 20 years and 12x in the last 10 years. I think it's fascinating to see that in 2020, with 3 months left and in the middle of a global pandemic, we're on pace to outnumber the papers that were published in 2019. And already for 2021, there's 12 papers published on the microbiome ahead of print. So definitely a remarkable area of research, and one that I hope you'll find is very relevant during early life. And so that brings us to our objectives for this morning. And what I thought we would cover are to hit some of the high points about why we're studying the microbiome and why this is so important in early life. And then to focus on a patient population near and dear to my heart as a newborn ICU nurse. What about the preterm infant microbiome, and why is this a uniquely vulnerable patient population? And then finally, just to take a little bit of time to see if we can answer the questions around, can we build a better baby biome? I don't pretend to answer this today, but we may have time to talk about some strategies that may optimize our preterm infants' microbiome. So to start, why are we studying the microbiome during infancy and early life? Many of you may have heard of the hygiene hypothesis. And the hygiene hypothesis postulates that microbial exposure in early life is important for the proper development and training of immunoregulatory mechanisms, and thus may prevent inflammatory diseases later in life. So it's not just our fascination with the microbes and the sheer number of microbes that live on and in us, it's also what they do and how they then impact our immune system that is really why we care about the microbiome. And we can see in this figure that there are many, many factors of the microbiome in human health that interact with one another. Everything from the promotion of fat storage to the biosynthesis of vitamins and amino acids, all different factors. But the two things that I'll take a minute to focus on, because they are so important in early life, is the development and training of the immune system and the resistance to pathogens. So what you can see here in this cartoon is an overview of the cytokine network regulating innate and adaptive immune microbiota actions in the gut. And if we start with the epithelium, which is the barrier, this responds to many microbial and immune-mediated signals, and in doing so, triggers a cascade of events that leads to our Th1 cell response. We then see examples in IgA. IgA is the most abundant antibody, and the induction of secretory IgA relies on intestinal colonization, which is extremely important at the mucosal surfaces, especially at mucosal infections. And this secretory IgA and ultimately IgA is altered by the types of bacteria. For anyone who's studied germ-free mice, they know that those animals are deficient in secretory IgA and IgA and thus are prone to bacterial infections. And then finally, another example, perhaps one of the most important examples, is seen in the induction of different mucosal CD4 cells, which follows intestinal colonization. We now know that specific types of bacteria, for example, Bacteroides fragilis and specific types of Clostridia, and bacterial products, for example, short-chain fatty acids like butyrate and acetate, stimulate various intestinal T regulatory cells, and these are important in controlling inflammation. So as you can see here, these short-chain fatty acids ultimately respond in stimulating our FOXP3 regulatory T cells with an anti-inflammatory TGF-beta response. So many examples of how the interaction between microbes and cells of the immune system stimulate the immune response. And here again, we have some very concrete data showing that as the number of a specific type of bacterial species, in this case Bifidobacterium, at 1 month increases, so does the secretory IgA response at 6 months increase. Interestingly, we see an inverse relationship between Bacteroides fragilis at 1 month and IL-6 at 6 months. Another example is seen in colonization resistance or resistance to pathogens. And so what we see here is that as the microbiota profile transitions from a simplified and high pathogen load to one that is characterized as diverse and abundant, we see increased colonization resistance. So if we follow this through, a simplified and high pathogen load is ultimately characterized by more pathogenic species and ultimately epithelial cell damage by these pathogen virulent factors. As that microbiota profile transitions over to a diverse and abundant microbiota, so characterized by many different types of microbes, we see an anti-inflammatory state or homeostasis with more commensal microbes present, and this expands our anti-inflammatory response, so the expansion of IL-10 producing T regulatory cells. And again here, there we go, we see this interesting window where the presence of different microbes in early life, so in this study in the first 2 months, was associated with immune response at 2 years. So here, where we see Staph aureus colonization associated with various allergic manifestations, so Staph aureus, high Staph aureus associated with IL-4 and IL-10, showing the opposite of commensal bacteria presence, lactobacilli. So when compared to lactobacilli, early Staph aureus colonization was associated with a reverse pattern of cytokine-producing cells at age 2. So this is very interesting because it gives us the idea that there are these windows of opportunity, which underscores again why we're studying the microbiome during early life. So at birth, our gut lymphoid tissue is uneducated, and the innate immune response to the presence of bacteria is crucial for that transition from fetal to postnatal life. And evidence and mounting evidence suggests that there are these time-dependent windows of development that are contingent upon microbial signals to trigger this maturation of mucosal immunity. So I think this is some good evidence to say why it is so important to study the microbiome and different factors that influence it during infancy and early life. So with that, there's also some very interesting clinical factors that influence the microbiome, and some of these are unique to infancy. So while we do know that the microbiome is influenced across the lifespan, there are some notable events that occur during the perinatal and neonatal period that seem to have a lasting impact on the microbiome. So things like maternal diet, gestational age at delivery, NICU exposure, perhaps delivery mode, and certainly nutrition. And when I think about this, I think of the big four: mode of birth, antibiotics, the environment of care, and nutrition. Today, what we can fit in the scope of our conversation is a discussion around how babies are born and how we feed them. But certainly there's increasing evidence on all of these different factors that may influence the microbiome. So to start with the mode of birth, many epidemiologic studies have shown association between mode of birth, specifically cesarean birth, and clinical outcomes during childhood, including things like obesity, asthma, allergy, and atopic diseases, all characterized by an inappropriate immune and inflammatory response. This is just one study, a very large study of 2 million children that showed associations with cesarean section and chronic immune disorders. So again, things like asthma, juvenile arthritis, irritable bowel or inflammatory bowel disease, and other immune deficiencies. And so because of these epidemiologic studies, translational scientists like Maria Dominguez-Bello were very interested in, could the microbiome be some of the mechanism explaining these epidemiologic findings? So it's hard to believe this paper, which was very significant when it was published 10 years ago, was one of the first to really show this. And so what we see here are that babies born via cesarean section seem to group together with a similar microbiome to that of their mother's skin. And babies born via the vaginal canal seem to group together with the microbiome of their mother's vaginal canal. And when we look at the specific taxa, we see here that the taxa in the mother's vaginal microbiome and the baby were largely lactobacillus. And interestingly, the taxa of the mother's skin and the babies born by cesarean section were characterized by an abundance of staphylococcus. And other studies went on to validate some of these findings. This is one where we see a decreased fecal microbiome alpha diversity over time, with babies born by cesarean section having a lower diversity when compared to their vaginally born counterparts. And when we look at specific taxa, again, we see decreased bacteroidetes in the cesarean-born babies when compared to their vaginally born counterparts. So as you can imagine, and you might have read in the New York Times how much interest there was in these findings. But many of us in the clinical community who take care of these moms and babies all the time said, well, that's all very interesting, but C-sections do typically occur for some medical reason. And many of them are listed here on this slide. One of the most common reasons that a C-section is performed is CPD, or cephalopelvic disproportion. And this is a term that means that the baby's head or body is too large to pass safely through the mother's pelvis, or the mother's pelvis is too small to deliver a normal-sized baby. So this led us to think about what other maternal factors may be playing a role in the microbiome of these children. And so a group in Texas took a look at this and really started to focus on diet. And what they specifically wanted to understand is, could it be that a high-fat diet during pregnancy persistently altered the microbiome of the offspring, regardless of whether or not the mother came into that pregnancy in an obese versus lean status? And so what we see from their results is that, and this was a rhesus macaque study, that the animals that were fed a control diet had a microbiome that clustered together. And you can see that in these lime green points in the principal component analysis. And interestingly, the animals that were fed a high-fat diet seemed to group together. And I think what's most interesting about this is that it was independent of the, say, BMI status that the animals entered the study. When we looked at the composition of the microbiomes, again, we see very little differences between the groups that were fed the high-fat diet, but we do see a difference in the taxa that characterize the microbiome of the offspring of the animals born to the control diet groups. And then again, when they dug into this data a little further and they looked at other factors that may influence the microbiome, things like and these are maternal factors, things like, did the mom receive antibiotics? Did they have gestational diabetes, mode of delivery, antepartum antibiotics, and or gestational weight gain? They found no statistically significant differences. But when, again, they focused in on this high-fat diet during pregnancy, they did see a difference in the microbiomes of the offspring. So we come back to this question: does mode of birth influence the microbiome of the offspring during infancy? And we're interested in this because it is such a potentially important clinical factor that occurs during the perinatal and neonatal period. And what we can surmise is that cesarean section is more common among metabolically unique women, so women who are high BMI and or who have diabetes or are prone to having a C-section due to a large for gestational age baby. Factors that can cause obesity, diabetes, and LGA infants, including mom's high-fat diet during pregnancy, may change an infant's microbiome from what it would have been if the mom had a healthier diet during pregnancy. So the takeaway from these findings may be that the factor that led to the mode of birth may also influence the microbiome of the infant. And there's a lot more research to be done in this area, but I think some very interesting opportunities to identify new targets for interventions that may optimize the microbiome of the baby. So moving from mode of birth to nutrition, we know that nutrition is important to microbial and ultimately immune health across the lifespan. But there are some very interesting factors early in life that, from a nutritional perspective, influence the microbiome, and that those pertain to breast milk. So we know that human milk has many unique factors that influence the microbiome, things like oligosaccharides, cytokines, and immunoglobulins. And then its own, and milk now we understand has its own microbiota. We're unclear about where that comes from, but there's much research occurring right now to better understand that. So to dig into this a little, we need to ask ourselves and understand what is in human milk. And really, 90% of human milk has been shown to be water. It's the 10% of macronutrients and micronutrients that becomes very interesting. And in that 10%, we see the majority are sugars, lactose, certainly fats, lipids, and proteins. But there are also these human milk oligosaccharides, or HMOs. And I think HMOs are fascinating because they're basically these long sugars that really have no nutritional value for the host or the baby. They seem to serve the purpose of feeding the commensal microbes what they need to colonize the infant gut. So there's many postulated effects of HMOs. The first is this notion of being a prebiotic. So the sugar that feeds the bacteria, so these good guy bacteria that then generate short chain fatty acids that can protect the gut, as we talked about in the earlier part of our conversation. There may also be some anti-adhesive natures to these HMOs that prevent pathogenic species from adhering to the intestinal lumen. And then there may also be an absorption or growth differentiation or a glycomodifying influence that ultimately improves nutritional absorption and optimizes cognitive development. So these are all postulated effects. We certainly have a lot more work to do to understand exact mechanisms, but we do know that they're important in how they impact the microbiome. And we see evidence of this here. So just some very simple data showing the relative abundance of firmicutes, so a type of bacteria, is directly associated with the relative abundance of fucosidated HMOs. That's different when the HMOs lack fucose, a certain sugar. And the same thing, an inverse relationship with proteobacteria. So a more pathogenic bacteria has an inverse relationship with the abundance of fucosidated HMOs. So we know that human milk is important, and we see now evidence demonstrating that this is true. So this is a rhesus macaque study again that looked at differences in breastfed and bottle-fed infants based on their diet. And so we can see that the animals that were nursery fed versus dam fed did have different microbiomes at 12 months and still again at 6 months, suggesting that in fact the nutrition did have an influence on the microbes in their gut. And we then wanted to emulate that study in humans, and so did a similar analysis in our preterm infants. And we found, in fact, that we took 30 preemies, 10 of whom were 100% human milk fed, 10 who were 100% formula fed, and then 10 who were fed our donor milk protocol. And when we compared the milk-fed and the formula-fed babies, we saw pretty clear clusterings in the principal component analysis, suggesting, in fact, that there were differences based on the diet of these infants. When we looked here, the analysis got more complicated, but also more interesting. And so here we learned that we had to start to account for the age of the baby in our analyses. And so you can see these open circles are younger babies, and the solid circles are older babies. And in fact, that gestational or that age at the time of the sampling made a big difference on how the microbiome clustered. We also saw that the formula-fed infants were most influenced by differences in gestational age, and that the mother's milk-fed infants seemed to be more resilient to this age factor in that they grouped together regardless of their gestational age at birth or the postnatal age at the time of our observations. And when we did some longitudinal analysis of this work, we saw overall similar trajectories of microbes from bacilli to enterobacteria to Clostridia, but that the bacilli seem to persist longer in infant formula fed, extremely low birth weight infants. And we were very curious about this question around donor milk. And we learned that in this study, donor milk in our extremely low birth weight infants didn't seem to bring the baby to a microbiome that resembled that of mother's milk. In fact, they looked more like infant formula fed babies. This was different in babies who were born at a higher birth weight, greater gestational age. So when we think about what we've learned about nutrition, and there's still many, many questions to answer, it looks as though mother's milk fed infants cluster separately from infant formula fed groups, and they also may appear to be more resilient to differences in gut maturity. When we think about donor milk, which really is perhaps only specific to preterm infants, we see early feeding with donor milk in larger, very low birth weight, but not extremely low birth weight infants appears to have a lasting effect on the microbiome. And we do see this succession of microbes over time, with formula-fed infants having higher bacterial diversity earlier and Enterococcus and Staphylococcus persisting for longer. We know that intestinal and likely immune maturity appear to be paramount in establishing the gut microbiota among preterm infants, which I'll talk about shortly. And we know that determining optimal microbial health and nutritional practices requires us to look at subgroups of infants at specific points in time. So in that previous work, it really required us to look at the babies in very specific, what we now call bins. So really getting specific groups based on the gestational age at birth and the type of nutrition is important in all of these different microbiota studies. There are a lot of gaps in the studies that have been conducted on nutrition in the microbiome. Some of them include measures of host response. So what are these bugs doing? What is the metabolic response? A need for greater clinical outcome measures. So what does growth look like and how might that be different based on the microbiome? And then more information is emerging about the milk microbiome, which we're very interested in, and how that may impact some of these outcomes as well. So we've talked about some intestinal biology and why the microbiome is important, and specifically during early life. And we've talked about some clinical factors that occur during the perinatal and neonatal period that seem to be pretty important to how the baby establishes their early microbiome. But being a preemie person and a newborn ICU person, I've been very focused, and I think we all would want to really understand our most vulnerable patient population, and that would be the preterm infant. So we know that about 1 in 9 babies are born too soon each year, and that when compared to their full-term counterparts, preterm infants experience greater risk of disease and disability in organs like their brain, their eyes, their lungs, and their gut. And these all generally have to do with an inappropriate or an immature immune response and inflammatory outcome. And so I'm most interested in GI disease and gut health. And so what we have come to learn is, like every other organ system, the gut of the preterm baby is immature. It has decreased mucus production, decreased IgA, a low intracellular junction integrity, and increased permeability. Some people call this leaky gut notion. And that, in the setting of an altered microbiota, which is often characterized by low diversity caused by empiric antibiotics, and perhaps polymorphisms in the TLR receptors, leads us to this exaggerated inflammation and tissue injury and intestinal necrosis. And this is common in the pathophysiology of GI disease I'll talk about shortly. And sorry, so the conclusion here is it may be that the immature gut is not ready for a dialogue with microbes the way that the mature baby's intestine may be. And so some good evidence of that can be seen here in some experiments that were done many years ago now, but really sort of show us how the fetal enterocytes may not be ready to interact with microbes. So this is a study that involved taking commensal microbes and exposing them to adult enterocytes versus fetal enterocytes. And what we can see in the mature enterocyte is that when the commensal microbe interacted, it interrupted this NF-kappa beta signaling pathway and inhibited the inflammatory response, as indicated by a decrease in IL-8, TNF-alpha, and interferon gamma. What was really interesting is that in the immature, the fetal enterocyte, when you expose those cells to these good guy bacteria, commensal bacteria, we didn't see that NF-kappa beta pathway interrupted. And in fact, we saw an inflammatory response. We saw higher IL-8, TNF-alpha, and interferon gamma. And so it may be that this inflammatory pathway of the I-kappa beta is developmentally regulated. So again, here in the mature cells, when they were exposed to pathogenic bacteria, something like Salmonella, they did see an increased inflammatory response, but that when they were exposed to the commensals, it was a much less. When the immature fetal cells were exposed to those same conditions, those cells had a much less different inflammatory response, again suggesting that the immature cells may not be ready or appropriate to interact with even commensal bacteria. So coming back to our preterm infant, so we know that they have immature organs and perhaps this inappropriate inflammation that may be associated with this immature response to microbes. And so that leads our focus to this inflammatory bowel disease called necrotizing enterocolitis, or NEC. And NEC remains a major contributor to neonatal morbidity and mortality. For babies who experience NEC, we see about 10%, greater than 10% mortality. And if a surgical intervention is required, that can be greater than 25%. And even for children who survive NEC, we see long-term morbidity and profound neurodevelopmental delay. And what's so troubling about this disease for those of us in the NICU is NEC is what I call a disease of preterm birth survivorship. So not surprisingly, preterm babies who don't survive, often it's associated with their immaturity in the first 12 hours of life. And then for those who survive to 72 hours or 3 days, we see that the cause of mortality, often all the way out to 7 days, is associated with respiratory distress syndrome. But after a week, so after, and this is what's so devastating, after children survive that first week of life, we start to see NEC as being a major contributor to mortality. And this has remained persistent over many years. This data is from 2000 to 2011. So we really want to understand if the microbiome may play a role in necrotizing enterocolitis. And we did an early study on this showing that, in fact, there was this increase in gamma proteobacteria in NEC cases when compared to controls. What our study taught us was that we needed to also be mindful of this notion of gestational age and postmenstrual age. Because it was very interesting to us that while we did see an increase in proteobacteria in all babies who got NEC, it was interesting that in the controls, compared in the early onset cases, there was no change in gamma proteobacteria, but later in postnatal life, gamma proteobacteria was coming down, while in the healthy controls, while the cases saw it going up. So this study, there were many studies going on around dysbiosis in NEC at this time. This is a paper from Barb Warner and Phil Tarr showing that dysbiosis is associated with NEC, with controls gradually but significantly attaining diversity over time, where cases did not. And then we all had an opportunity to collaborate in a meta-analysis, pooling data from 8 groups across the country, looking at this question of intestinal dysbiosis preceding NEC. And what we saw was that proteobacteria was in fact increased in cases when compared to controls, but it's not just a story of pathogenic bacteria, it's also a story of commensal bacteria. So firmicutes were higher in controls, as were bacteroides. We also saw an overall greater diversity in the microbiome of babies who did not experience NEC when compared to their counterparts with the disease. So all of this is to suggest that babies who develop NEC do have differences in their microbiome. And that's very interesting, but we want to understand why this matters and what these microbes are actually doing in the gut. And so if we take proteobacteria, for example, these are gram-negatives. They're mainly facultative anaerobe species, and they include many pathogenic species that are TLR4 agonists. They have a high LPS in their cell wall. So some of the specific taxa may be things like Campylobacter, Enterobacter, and Klebsiella. Firmicutes are gram-positive. They're typically obligatory anaerobes, and they're highly abundant in the gut microbiota, and we also call them highly bioenergetic. So these are the bacteria that manufacture short-chain fatty acids like butyrate, which, if you remember back to our intestinal biology, help stimulate those FOXP3 cells that attenuate inflammation. And then bacteroidetes, again, gram-negatives that are obligatory anaerobes, are often abundant in the gut microbiota and also play a role in converting T cells to FOXP3 anti-inflammatory cells. So it's not just enough, I think what I'm trying to share with us this morning is it's not just enough to understand that there are differences in the microbiome in particular patient groups, but we also need to understand what those differences are and then why they matter from a biological perspective in the immune response. So this brings us to this question of, is it possible or can we build a better baby biome? And so the first thing, of course, that I have to talk about are probiotics. I know many of us, we can't walk through the grocery store or the health food store without seeing many, many different probiotics marketed to us in our wellness. And so, when we see what's been marketed, we see for term infants, there are probiotics for indications of restoring the gut microbiome or preventing asthma or atopic dermatitis or easing colic or optimizing growth. There's so many different indications. And for the preterm infant, these have been marketed to prevent NEC or sepsis. So there's many, many different products with many different claims. And I think that there's certainly some promise in this area, but I think as scientists, we have to take a step back and, be rightfully do some good work in really analyzing the data that's available. So we first need to understand, well, if we're going to use probiotics, how do they work? And of course, we don't know all the answers to this, but there's suggestions that perhaps they work through competitive exclusion. So they have perhaps bactericidal factors, or they increase mucin production or decrease pH, which inhibits the colonization of pathogenic bacteria. Perhaps they have a role at the epithelial barrier, where they decrease bacterial translocation or antigen translocation. They have been shown to have an anti-inflammatory impact in increased IL-10 or decreasing IL-8 and TNF-alpha. And they've also been shown to play a role in inflammation, so increasing IgA, IL-6, and NK cell activity and phagocytosis. These are just some of the ways that probiotics may work. And not surprisingly, they have been the topic of many randomized controlled trials in preterm babies. And so when all of these meta-analyses were put together, we do see an effectiveness of probiotics for NEC prophylaxis, both in the incidence of NEC and the overall mortality, and the incidence of sepsis, but interesting, not for mortality due to sepsis. And so there's some politics about probiotics and some pushback in that there have been 20 randomized controlled trials to prevent NEC, and Cochrane meta-analysis reported that enteral probiotics significantly reduced the incidence of severe NEC. Other meta-analysis adding studies came to the same conclusion. But of course, these RCTs have been controversial. And one of the most controversial factors around these RCTs is the underrepresentation of low gestational age babies who are at greatest risk of NEC in the trials. And this led to the PIP study, which was a study conducted in the UK that only focused on very preterm infants, 23 to 30 weeks. And this study, as you can see from the confidence intervals, did not find significance in reducing NEC, sepsis, or death before discharge. So this is a very interesting study because the findings showed that the routine use of probiotics, while safe and while likely modifying the gut microbiota, did not support the routine use to prevent NEC and sepsis. And why many of the community members feel this is an important study is because there was a more representative population of infants at risk of NEC included in the trial. Other interesting notes is that the intervention was at the strain level, and the research data has been at higher levels of the taxonomic tree. And so this also suggests more research is needed. So then the other thing I want to highlight about probiotics is that the manufacturing process is complicated. And so this is a study that was done in California at Davis, where they took 16 probiotic products and subjected them to bacterial sequencing to see if the taxa that was in the vial actually matched its label. And what they learned is that only one of the 16 products that they studied had a microbe that matched what it said was on the vial. And so the prevalence of misidentified bacteria, specifically bifidobacteria in these products, has caused concern for those involved in clinical trials and certainly consumers of probiotics. So all this is to say, why do we have this reluctance around using probiotics? And there's many places in the country and in the world that have adopted these in practice. But I think I would argue that there's still an underrepresentation of low gestational age infants at greatest risk in the studies that have been reported. There's many preparations that have been used in the research studies that are not readily available for clinical use. There's a high degree of variability in the contents among the probiotic preparations between the label and the contents. And then from a manufacturing perspective, there's a lack of regulation in production. So in the United States, probiotics are considered a dietary supplement and thus not subjected to FDA oversight in production or quality standards. There have been isolated case reports of bacterial sepsis with probiotic organisms. And then finally, as we learn more about the microbiome and the dynamic nature, especially in preterm babies, there's conflicts in the taxonomic level of the bacteria studies and the bacteria used as therapy. So I think what I would conclude is right now, there may very well be a place for probiotics as a microbial intervention, but the products that we have available seem to be a fairly blunt tool. So on the opposite side of probiotics are antibiotics, and there is no lack of literature on the associations between antibiotics, the microbiome, and NEC as an example. And perhaps one of the most interesting papers is now somewhat dated, but came from Michael Cotton and colleagues showing that the greater amount of empiric antibiotic treatment a preterm baby received, the greater their risk of NEC and death. So there's a lot of curiosity, and this is not new, around how we should use antibiotics in the NICU. And if you look at this study that was published in Pediatrics long ago now, we see that the number two, the first and second most commonly administered medications in the NICU, of course, are ampicillin and gentamicin. And if you look at the top five, that makes 3 of the top 5 most commonly used meds in the NICU to be antibiotics. And we know, of course, from many studies that antibiotics result in a low diversity microbiome where no antibiotic exposure is high diversity. And so again, I'm just going to highlight one study that has really looked at this and has shown that antibiotic exposure does delay microbiota maturation in early life. We see that in the microbiota by age Z-score, that infants who are exposed to antibiotics have a lower microbiome. It does seem to increase, but then decrease again when compared to their unexposed counterparts, and that there are differences in the taxa of the babies who are exposed versus not exposed to antibiotics. And then when we look more carefully at this data, we see that the red shaded taxa, or rows, shown here, so things like bacteroides, were significantly more abundant in antibiotic-exposed infants at given time points, whereas the blue shading indicates more abundant taxa in unexposed infants. So again, definitely suggesting that there is an impact of antibiotic exposure early in life, perhaps all the way out into early childhood. So when we think about, can we build a better baby biome? Certainly there are strategies, perhaps probiotics, definitely antimicrobial stewardship. We know there are many units that have done a great job in decreasing the antibiotic exposure to their preterm babies, but we still have a lot of unanswered questions about which babies do need antibiotics, and hopefully the randomized controlled trial looking at this, the NANO study, may help guide our clinical practice. Perhaps mode of birth, but perhaps more importantly, different maternal factors may be important in optimizing the microbiome. Nutritional interventions like a human milk diet and perhaps the administration of HMOs may optimize the microbiome for infants, but whatever strategies come forward to be these microbial interventions, all of these potential strategies require new tools to assess and direct interventions focused on microbial immune health. I would say that right now we don't quite have all the tools we need to know which babies require which interventions and for which outcome. And so that to me is a good thing. That means that there's a very bright future for microbiome research, and one that I hope we all collectively can make a contribution to. I've worked with many great groups and with the wonderful support of many organizations. And I think with that, I'd certainly say thank you, and we can open this for some discussion.
All right, great. Thank you so much, Kate. We have a couple questions. I believe Joel asked a question when you were talking about mode of birth, and his question is, do you think that deep suctioning may play a part in disrupting that process?
Deep suctioning during mode of birth?
Yeah, we asked him for clarification as to exactly what process he was referring to, but you were talking about mode of birth at the time he asked his question. Perhaps we can come back to that one. Joel, if you're still on, please respond. What strategies might help ensure a human milk diet for preterm infants?
Yeah, that's a great question. I know that many NICUs across the country have had very aggressive efforts in helping to support moms in making human milk available. I think of Leslie Parker's work, where they have done interventions to start supporting mom with pumping, even in the delivery room. So certainly I would say early pumping and really supporting these moms who are not like the moms of term babies. They need additional nutrition and rest to really be able to establish a milk supply that can meet the long-term nutritional needs of their babies.
Great.
I hope that answers the question. Yep.
Yeah. The next one, could variance in maternal HMO secretion influence or mediate the effects of mother's own milk on the infant intestinal microbiome?
Yeah, I think if I understand the question, could differences in the maternal HMO profile impact the human milk microbiome? Absolutely. I think it's very early days in understanding a lot about the human milk microbiome, but we're very intently focused on that and are doing a study right now to see what factors, perhaps in addition to maternal HMOs, impact the mom's milk. So is it something about her diet? Thinking that there's the enteromammary translocation idea to the milk microbiome, or as we may know from the child study, is it something about the baby? And so the microbes that live in the baby's mouth, there may be a retrograde hypothesis that also influences the milk microbiome. So I think that's a very interesting area of study where we need to learn a lot more.
Great. So the next question is, should we give probiotics to preterm infants?
The $1,000,000 question. You know, I think, as I said, I think right now, I think there's many things that we don't know. And I always say there's absolutely a place for prebiotics or probiotics in the NICU. But I think until we have a tool that tells us which probiotics to give to which babies and when, I don't think we're in a place where this is the right intervention. I think that those tools are coming. And once we have them, I think that they may very well improve outcomes for our preterm babies. Okay, as in DeLee suctioning. Gosh, I don't know the answer to that. I still don't see how DeLee suctioning is associated with mode of birth. But maybe I'm just missing that. I see it in the chat.
Oh, okay. I see.
Sorry, Tammy. I can see in the chat from Elizabeth Kim.
Okay. We did have a clarification on that question, so let me ask it this way. Do you think deep suctioning may play a part in disrupting the microbiome?
Oh, that makes more sense.
Okay.
Got it. Okay. Yeah, so it almost certainly. We don't know for sure, but there have been some studies that have looked at gastric pH, and that may influence the microbiome, and so that deep suctioning, which may influence the pH, may also in turn influence the microbes that colonize the gut. There's also a question here: would choreo affect the gut microbiome? There has been some work done on choreo. I think, though, we don't know the answer to that. Choreo would be an infection that we would see late in pregnancy, and so I don't think we have enough to say that would influence the baby's microbiome, just given that it comes often very late in pregnancy.
Okay. Another question about antibiotics. How should we be using them in the NICU?
Another $1 million question. Cautiously, I think, is what we would all agree. So, as a old newborn ICU nurse, I definitely have seen the impact of sepsis on preterm babies and the catastrophe that is. And so there is definitely a place for antibiotics. However, I think we also know that place may be more specific than we initially thought. So the sort of universal empiric amp and gent for every baby admitted to the NICU is almost certainly not ideal. But we do know there are some babies, especially preterm babies, born, for example, in the setting of choreo, that are at great risk of sepsis. And so what we're trying to work out right now, and I do think this large randomized controlled study, the NANO trial, is trying to determine which of these groups of babies require antibiotics. And my guess is that it will be just like everything we're learning with the microbiome, that we need a more tailored and personalized approach to the microbial interventions we subject these babies to. So we'll probably learn that certain babies who are in certain gestational age strata, born in the setting of very specific sepsis risk factors, are the babies who we should give antibiotics to. And other babies not born in those settings, we will feel more comfortable doing watchful waiting and holding back on antibiotics.
Great. Well, I don't think we have any more questions. The only thing folks have asked us is if you'd be willing to share a copy of your presentation and potentially your references.
Sure, happy to.
Okay.
I think the webinar is recorded, so you can see the slides there, and happy to share the references.
Perfect. Okay, great. Thanks so much, Kate. We really appreciate your time and all your insights.
Thank you. It was my pleasure.
All right, take care.